as you can, please.
Well, I'll go real quick. I'm not really that new to OMOP, but hi, it's Ben Hamlin. I'm with NCQA. I am joining this group because of the recent HL7 Odyssey workshop, where I was running the quality measure use cases, and there's a lot of interest expressed from that group on how we define phenotypes in the Odyssey world versus how we do it for denominators for measures, for example, and the use of CQL. And so I thought I better start getting more active in the phenotype group so I can continue on exploring in that area.
Welcome, Ben. So happy to have you. That's awesome. It's Ben and I have been associates for a long time, and this kind of is culmination of a long-term dream. Anyone else?
Hi, this is Elise Berliner. I'm from Cerner, where I just started. Previously, I was from AHRQ, and I'm more of a health services researcher, but I'm trying to learn about all these issues with electronic health records, phenotypes, and all these other informatics issues.
Excellent. Thank you, Elise. Welcome. It's great to have your perspective from electronic health record expertise. Anyone else? Okay. So this is the recap. I'm sharing my screen right now. For newcomers, we have an Odyssey Teams channel. It's called the Workgroup for the Phenotype Development Evaluation. So if you have access to the Odyssey Teams, which everyone should have access. If not, please contact me and I'll direct you to the right way to get access. So once you're on the Workgroup page, there are several channels here. We are in the general channel. The general channel is when we make the mass announcements. This is where you also get the meeting invitation. The work group, which met, this is the recap of the work group from last week. This is a recap of the last meeting that we met on September 4th, Friday. The notes are here, the recordings are there. We decided on an action item. We started talking about COVID, and we divided our work into 3 problem areas that we wanted to tackle. Problem area 1, are clinicians coding people to have the diagnosis of COVID disease? When all they're trying to do is justify the bill for it. If the clinician says that somebody has COVID, do they really think they have COVID, or they are trying to justify a bill? Or is it because they found a person, the patient came to them with their signs and symptoms of COVID, they gave a clinical diagnosis, but then a test result came back maybe same day or the next day after they had already labeled the person with COVID, and the test result was negative. What do we, so what we're trying to tackle here is how often are we observing COVID diagnosis with a negative measurement? And if those are present in the data, how do we handle them as a phenotype? So that's essentially the problem statement number 1. The problem statement number 2 is the differentiation between acute COVID disease and long COVID. Long COVID is now a big public health concern. A lot of individuals are studying it. At the same time, what we are observing in the data is when somebody is diagnosed with COVID, we don't know if that index date represents a new onset of an acute disease or is a continuation of a long COVID. So we want to differentiate those. And then the third one that we discussed was the data capture pattern of COVID. So obviously, in the first part of 2020, we didn't know anything about this disease. We had shut down. We were like ostrich with our head under the sand. We now know some about the disease. We have a vaccine. So maybe the pattern in which the COVID is being documented in the healthcare data has changed. So maybe do we need to have different strategies for COVID in 2020 versus COVID in 2021? So those are the 3 problem statements that we discussed. And then we divided into subgroups. Like problem statement 1 was I took the lead on it. Problem statement number 2, Evan initially took the lead on it, but it has now changed. And so I'll give the work group an update. And then problem statement number 3 has not been tackled by anybody as of yet. So I'll quickly go to problem statement number 2 because I think that's meaningful. And I don't know if anybody who's okay. So quickly about problem statement number 2. The problem statement number 2 is now owned by Anika. Anika is a representative from Oxford. She received a grant as part of her work to phenotype and characterize and study long COVID. She approached the work group members through another OHDSI work group, the vaccine safety work group, and they have now proposing a plan to tackle problem statement number 2. So that more details on that is yet to come. Problem statement number 1. So today's focus is on problem statement number 1. We have to talk about a few things. One, what happened after we defined this problem statement? What happened in the past 2 weeks? What is the work so far? What is the insight that we have drawn from the work so far? And what is the next steps? At the end of the meeting, in the last meeting, we asked for volunteers. Patrick and I, we sat the rest of the time, and we thought through it and kind of brought an idea together. So if you go here to this channel, the COVID phenotype, that's where we are focusing and managing the content. I have here 4 documents that I want to quickly go with you. One is an outline, and then there is a manuscript that is under works. Then there is a document that I want to show you. That's one artifact that you have access to. A second artifact that I want to bring to your attention is a Shiny application, data.ohdsi.org/COVID phenotype. And you have access to this. This is the cohort diagnostic execution on about 20 cohort definitions, candidate definitions for COVID. So as to tackle problem statement number 1, which is COVID phenotyping, the work done so far is we went crazy and built 20 different cohort definitions, and I'll go through those cohort definitions. We ran that on 2 data sources that have both diagnosis and lab measurements. We studied how those individual definitions behave. We drew some inferences based on that, and then we made a recommendation, or we are very close to making a recommendation of a cohort definition to move us forward. We're going to take that new cohort definition and then create a network study on that cohort definition. That will be the part 2 of the study. So that package will be available on our OHDSI Studies Git repository. Some data partners have agreed to run that. Data partners from Stanford, from Vanderbilt, from Spain, I believe, and N3C. So we'll be attempting to run those and bring the results from that. So that would be like an external validation. So that's kind of the high-level summary of the idea of how this project, how this problem statement is being tackled. So that's about the problem statement. Now, the work done so far, there is a manuscript that I've been working on, and here it is, and it's also available to you. I'll go over that work too. There is this artifact that I want to show you. That's and we need to go through these definitions. So, any questions, thoughts, or comments as of right now before I go into more details? No? Okay. All right. So I'm going to start out with some discussions that happened before. In the COVID vaccine safety work group, one of the group members said, in our data source, I think Columbia University data source, they found people to have a COVID diagnosis, but on the same day, a negative test result. So that kicked off our evaluation process. The first step was to confirm if those are also observed in other data sources. So we built a cohort definition that basically said you have a COVID diagnosis, and on or around the same day, a few days before, a few days after, you have a negative test. That gave us a significant number of people. So that means that in another independent data source or a larger data source, there were people that met the definition of a COVID diagnosis, but a negative test result on the same day. So we thought through this in many different ways, and that's the detail. But the main point, I think, is this particular visualization. This is something that Patrick put together, and it's a brilliant thing, and I have enhanced it a little bit further. So what is this? I'm going to first orient you to this visual. So the columns here are labeled D, 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 and a number. If there's an M, it's a minus. So that is day -5, day -4, day -3, day -2, day -1, day 0, day +1, +2, +3, +4, +5. These numbers have a meaning. If you have the number, if a cell has the number 1, that means that you had a SARS-CoV test negative on that day. If you have the number 2, that means you had a SARS-CoV positive on that day. If you have the number 3,
I think flip that over, Gowtham. 1 is positive, 2 is negative.
Is that right?
Yeah, 1's positive, 2's negative.
Okay. I'll take it from you because I'm unable to verify right now. Okay, 1 is positive, 2 is negative. Thank you for the clarification. And 3 is gray.
What is each row in this file?
Each row is a unique combination of a positive test, a negative test, or positive and negative test on the 10 days starting -5 to +5.
Thank you.
What did you say 3 is? Sorry.
3 is on the same day you have a positive test and a negative test.
I see. Thanks.
Is this the date the test was ordered or the date the test result came back?
Our understanding from the data source, it is the date the test result came back. Patrick, please correct me if I'm wrong.
So it's in OMOP CDM parlance, it's the measurement date, but it depends upon the ETL as to what the individual source, what that's contributing. In the case of these two particular databases, for Optum DOD, that is the result date that's basically coming from LabCorp. So that it is the date that LabCorp processes the information. So it is not the order date. It's the test. It generally would be the date that you went to the LabCorp to get the thing submitted, not the day that the result ended up back, but it's called result date in that context. In the Optum EHR, because that data has already been transformed before we do the transformation in the CDM, it's a little bit less clear because it itself is a measurement date. So we believe that it is the date of the measurement. But it's almost certainly it's variable across the contributing institutions there.
Right.
One more question.
Mm-hmm.
So this is among the people who have a diagnosis, and day 0 is the diagnosis date?
Correct. Day 0 is the diagnosis date.
So all these people have a record of a diagnosis of COVID?
Correct. So if you look at this, the numbers here, the total number, when you add it up, it's more than 1 million. That many people had the COVID diagnosis in that data source.
And one more follow-up question. And the first row, when it's all zeros, it means this is the number of people who never had a result, who never had a
recorded in the database.
Correct. This is Optum DOD. Optum DOD is a predominantly claims data with some fraction of lab test reporting. Compare and contrast that to Optum EHR, you see a much higher fraction much lower fraction of people that had only diagnosis. So when you start looking at this, we start seeing patterns, right? Obviously, I need to reverse. Green is positive, red is negative. There are some people with negative test results on the day of diagnosis. It's not a very high number in Optum DOD. It's 0.2%, but it's there. In Optum EHR, the number is slightly higher, but it's all there. Patrick, this is a different calculation than the calculation you had written because this is cohorts being compared to each other. So it's a little bit more precise and the numbers match the numbers that are that the cohorts would lead. It's the same query though. So the immediate insight, like we are seeing patterns. We are seeing people who have a positive test result on the day of, and this group, I would say, makes sense, right? You have a diagnosis and you have a positive test result. So I would say that this is good. Now, interestingly, this particular group had a test result that was after the diagnosis. The diagnosis preceded the test. For this group, the test preceded the diagnosis. This
Yeah, and for those two, for row 4 and 5, just to reinforce the uncertainty we have associated with the date of things, we don't actually know if that was the date the test was administered or the date that the result. So it could very, very likely be, since it's a result date, is like that's the date that the result took place, but it could have been on a sample from 2 days ago. And that would be quite plausible given the 24 to 48 hour lag in testing. So I think, this, for me, when I looked at this initially, it was giving me a sense of just the magnitude of noise when interpreting test values, as opposed to being like having some sort of complete confidence in, which date is exactly right. Like I interpret those first 3 rows as plausible situations of a positive test that may have taken place on the test may have been administered on day 0, but then the results, came in tomorrow or the next day.
Yeah.
And do you know if these are all PCR tests, or are rapid tests also put in the EHR? So is it possible they were doing a rapid test and didn't record it and only the PCR test is getting into the EHR?
We can't, I mean, I think my answer is going to be, and somebody else can chime in too, who knows electronic health records better. My answer is going to be based on my understanding. It is, if in electronic health record, if the test is scanned, it's in. If it is not scanned, even if it's just a bedside test that is not coded for scanned for some reason, why would it go into the electronic health record system? The difference between PCR versus some other test, it all probably depends upon the policy of the local organization. But we have made an attempt to define a concept set expression that captures the antigen test.
The only thing I'll just add to that, Gowtham, is you're providing the speculation of what it is, but we have data in your cohort diagnostics to at least summarize what is the concept that is showing up for the test. And so that can at least, many of the times it is just mapped to something that only is telling you about a SARS-CoV antigen test without specificity of the exact test itself. So sometimes we don't have that information available, but sometimes you can see the specific type of test in there.
Right. So like, yeah.
I'll chime in with a question, and relates, I guess, to Optum as a data source in general. In their description of it, at least in stuff I've read, they mention the extent to which they do processing of natural language to generate some features, but I don't have a good understanding as to whether or not that winds up into being consumed through the OMOP ETL. Like, I'm just wondering, are the diagnoses that we're seeing here labeled, are these based purely off of a problem list, a claim, or does, are there textual features that wind up populating that as well?
And in this context, it's going to be diagnosis code 7.
Okay. Okay.
So what I'm going to pull up now is,
to your earlier speculation, Gowtham, about I guess the greater likelihood of things either not being entered or not being entered with any specificity done rapidly at bedside, rapid testing bedside. That is probably one of the things that fluctuates over time. So you led off with some description of that as a problem. I think during periods of heightened focus on COVID and ascertainment of COVID in the population, probably their data capture is more scrupulous and staffing is at a premium. There are factors that are related to overload and just how important getting the details of that information are that probably vary over time.
I just wanted to point another thing out, is that it seems that you guys are discussing like the details about how data is captured in this specific data source, like whether it's a PCR, whether like it's coming from claims, whether it's a measurement date or the order date. But I just wanted to say that this is the pattern that we not only see in one data source, right? Like in Colombia, we will see something similar, is that people sometimes have positive diagnosis, negative test, and then the time can vary and so on and so forth. So it's not specific to this source, which make me think that it may be useful not to focus on where all of these patterns that we observe are coming from in this specific data source, but rather what are the things we're looking at in general. Like, are we looking at the different subsets of COVID patients? Do we need to maybe look at the different subcategories? Do we need to have this information about the specific type of test? Do we need some additional information? Like, I think it may be useful to think about this problem in general. Like, what does it mean to have two different pieces of information that conflict each other?
Perfect.
And how?
Perfect. So, absolutely, Anna. That's thank you for that leading discussion, because here is what I'm trying to show is the exact same idea, I think. So you have 4 core definitions here, and like Anna is asking, are these people different? And that is the question that we need to answer, because we don't have control over what the data source is providing us. Here, there are 4 definitions. They are labeled C1, C16, C7, and C9, and the details are here. I'm going to quickly go over it. C1 is our current most common definition that has been used in majority of the studies. You either have a COVID diagnosis or you have your positive COVID test. If you meet for any one of this, you're in. That's C1. C7 and C9 are variants that are just I'll explain that in more detail. C16 is the new cohort definition that we are recommending for the community to use moving forward, if it holds true in external validation. So from C1, I'll go to C16. C16 is you either have a SARS-CoV test. There's a different version of it. Just hold on. C16 and there. So it's C17. C17 is you either have a positive test or you have a diagnosis with exactly 0 negative tests on the around the diagnosis. So let me show that in Atlas. I think this is it. So if you have a test, this part here is a measurement of SARS-CoV test. If you have a test and the test is positive, you are in. Now we go to the second segment here that starts at this portion. Or you have a diagnosis of COVID and any one of these, you do not have a test, or you have one positive but no negative test.
So these would include that first row there where you had zeros all the way across, right?
Correct.
Yeah. This brings in the vast majority of people, at least in that one data set.
Correct.
I couldn't read it, Gowtham. What was the time in which you have no negative test? How's that defined temporally? It's just too small on the screen that I'm looking at.
Plus or minus 3 days.
It's three before, 3 after.
And that's the one that's being recommended going forward for the community to use, is that right?
Yeah, so the 3 days, and I need to explain that more. The 3 days was based on looking at this one. Like the numbers dramatically go down as you go further from day 0. Most of these testings are clustered around the 3 days. So we are able to capture a big chunk of these numbers up within 3 days. So there's really no point in going more than 3 days, I think.
So what that means is that if somebody has a diagnosis that has a negative result and absence of a positive result within 3 days, those people will be filtered out, would not be considered as COVID cases. So they have a diagnosis, but they have a negative results and they don't have a positive result, correct? Because if they have positive results on their own, they will be in from the first rule.
Correct.
So,
so somebody can get in with just a positive result with no diagnosis?
Yeah.
Okay.
So we'll be leaving the positive test under any consideration. We are also believing the diagnoses. The only condition we're not believing the diagnosis if there is a presence of a negative result within 3 days without the presence of a positive result.
So this is where I actually think some of the questions that were being asked were material, because I think they were trying to get to, what's the clinical process behind how this data is generated. And I think the concern would be what we're seeing evidence of in the data is that, certainly like the COVID diagnosis code is being used in a rule out COVID clinical scenario commonly, right? Because we're seeing all these negative tests that follow, the positive presence of a COVID diagnosis. And so the question is, how many in that top row, which is, a bulk of the data, are just people who get assigned the same COVID, rule out COVID, but then are lost to follow up with respect to the testing results. Actually, I think a lot of times these weren't being administered in the clinic. Like a lot of times they may have, these may have been phone visits or may have been some other thing when they're often, and I have to speak I don't want to generalize too much around how different health systems are handling this, but a lot of the testing was centralized, at testing locations, at least speaking from my experience, kind of where I'm practicing. So they weren't even administering them in the family doc office, and they may or may not have gone to go get a test or that's the core of the question. And some of those things around, our rapid serology things getting reliably kind of consumed or brought into the EMR, I think are material, because a lot of this could be, it calls into question that I would doubt the veracity of a COVID diagnosis code based on the data that we're seeing here, because there's so many of these rows that have a negative test after the occurrence of the code.
So I would go back to answer Evan. I'm just thinking, going back to Anna's point. Well, we can actually start looking at this by looking if it's like Gowtham, if you have identified those as a group of people, we can look at them and see, if they are different, and then we can see if there's something in the clinical practice that explain that phenomena, which should manifest in some different, like these people should look different than the rest.
So exactly. So I'm highlighting a cohort definition here, C9. C9 are people with a COVID diagnosis, but have a negative test result within 3 days of that diagnosis. they do not have a positive test result. So to reframe the question, we are saying, are these people different from the COVID patients in some way? Are these really the rule out patients? And if we can somehow look at their features, baseline features or other features and differentiate this group from the other group, then maybe we have a case. But I don't know of other empirical ways of saying if this group is different from the other group.
So not on the basis of there being different groups, but I still have a problem with the same thing as during the last meeting, that the negative 3 days definition for the temporal window just doesn't make sense. I think if in early on, the evidence seemed to suggest that after infection, it might take as many as 7 days for a test to actually detect it.
Yep.
And so there's just no logical inconsistency between a negative test result 3 days prior to a diagnosis that suggests that there's anything incorrect about the data. There's also the possibility that data are just resulted at different temporal intervals relative to when they actually occur. And that we know that happens all the time. And that's, so there's some artifact associated with that. But just in the terms of like when an assay has actually got enough virus to actually detect it in your system relative to when you get a diagnosis, it's still not clear to me, the logic for going 3 days ahead of time. I don't think it matters. That doesn't seem like it matters that much in terms of the numbers that were going to be lost, but I don't get the logical basis of inferring that this was done as a rule out.
So Andrew, let's actually go through that. So don't talk about it conceptually as plus or minus 3 days. Let's look at these rows. Tell me which scenario happens that you object to. Is it row 8, where the negative test is the day after the diagnosis? Yeah. Are you okay with that one, or do you have concerns with that one?
I do not have any concerns with tests occurring after the diagnosis.
So is it row 23 then?
21, yeah, or 20.
So
Yeah.
Qualified.
Well, no, I guess it's maybe
20, 23, 24.
Negative test is 3 days before.
Yeah.
And then there's no evidence of any test plus or minus after that. Is that the one you're concerned about?
I guess so, yeah. Maybe that one and the next.
Yeah, 23, 24, 25.
And so the next one is
23, 24, and 26, I guess.
That's 4 days.
Yeah, just 23, 24, and 26, I guess.
26, okay. And the specifically 24, that's the day prior. So I just want, I'm not challenging, I just want to make it clear. Like, I get what you're saying. It is biologically plausible that someone is negative, has it in their systems, becomes positive, they develop the disease and whatever. So totally get that. And we're talking about the when can that happen? If the day before you got a diagnosis, you got a negative test, is it your discomfort is you think that that's acceptable? Yesterday you got a negative test, today you have COVID. Diagnosed, not tested positive, but it's diagnosed with COVID. And you want to consider that a real case?
Yeah.
Okay.
I think.
I mean, why would you get diagnosed with COVID if you just had a negative test? If the clinicians are aware of the negative test, you must be, for whatever reason, developing symptoms or.
So the testing information, I think, is like the idea. Somebody comes in and says, it didn't happen here. It wasn't recorded in my system. I, just came from this lab and got my results or whatever. And then, I don't know, but I mean, to me, it's not that it's plausible. And I'm picking at a fine point here, so I don't want to distract too much of the thing. But to me, it's not just plausible. It's expected that if you were infected very recently, you wouldn't have had enough time to actually develop enough viral load to be detected by the assay. So for anybody who's infected recently, it just doesn't, like there isn't enough time yet for the test to give you an accurate result. And that, if that's true, and I think it was early on, I don't know about with Delta or at least my understanding is it was true early on. That's the reason that those are not logically consistent. But I guess you got that already. So I don't. Yeah, I guess I've said.
I'm not. Just to orient what we're doing here. So what you're positing is instead of a plus or minus 3 days, it could be a 0 to 3 day option. And empirically, if that was the question that we were interested in, we could evaluate the empirical consequence of that choice of changing the minus 3 on the left-hand side to be 0. What we're seeing in this spreadsheet that can give us some sort of relief is we can actually see that the real consequence of introducing negative tests is actually on the right-hand side. Those are the situations we're actually trying to clean up here. And to Evan's point that he raised earlier, what this data actually exposes is the real elephant in the room is what to do with a diagnosis code that has no positive or negative test, because there all of the uncertainty of whatever it is must exist in that object. And like the real choice is, do you keep them in, or you're either going to keep them in knowing that they're not specific, or you're going to remove them knowing that you've lost a huge amount of sensitivity.
To me, that provides context for the inference you make about why there might be a negative thing, or a diagnosis that's happened in the presence of a negative test. There's just a lot of people for whom there is information relating to a diagnosis that isn't based on a recorded test in the system. That's, to me, what sort of the bottom line, where I assume that's the situation we're in, and informs my understanding of the other smaller case. But I agree that is the elephant.
And if just to try to a finer point, Gowtham, if you could scroll down a little bit, we saw some really fun cases down that are less common, but I'm going to find one real quick. If you stop, stop anywhere here, like, there you go. Stop, please.
You want the negative all along, right?
So like row 141, for example, you've got, they were they had a negative test 2 days before and a negative test 2 days after, but then a diagnosis in the middle. So like in that particular context, Andrew, like we can think about so now your logic, if we just move it to 0, this will fail no matter what. But I would say that when we look at these rows, you can start to you can end up conjuring the story in your mind about what's happening. But like in the case where you had a negative test before, a diagnosis, and a negative test after, there's just really no way to get behind that they legitimately, that's got to be a wrong diagnosis.
No, I don't think so, because a lot of times people are getting tested because they were exposed to somebody who was a known case. So here, I just found a paper, I could put it in the chat. So it says on the 4 days of infection before typical time of symptom onset, the probability of a false negative result of an infected person decreased from 100% on day 1, 67% on day 4. On the day of symptom onset, the median false negative rate was 38%. This decreased to 20% on day 8. So one can imagine that somebody was exposed to somebody with COVID, and then they were tested, and then 2 days later they had symptoms, but then 2 days later they're still showing negative. That's totally consistent with the, these aren't very many people, but that's consistent with the false negative rate.
Yeah, that's fair. So we can conjure up lots of stories about all of these things. And I think Anna's framing of it is a really good one. What do we do in the face of information that seemingly is contradictory, but may not necessarily be so?
Yeah, and then we always have the option of just saying we know this and go back to our initial definition. You have a diagnosis or you have a positive test result, you're in. But we have information now.
I would encourage us to look at the cohorts by these definitions. To me, if they all look similar statistically, then you don't have an argument that there's something wrong with somebody testing negative and have a diagnosis. But if you see something off about them, then you start thinking, if all of them look similar, we see the plot and they all have the same distribution, then then there's no definition different than the other. At least you don't have evidence. But if you start seeing a different distribution, then at least you know that they're different people. I don't know who's have COVID and who doesn't, but at least you have evidence that there's something different about them.
Well, and again, going back to your point earlier, Gowtham, I mean, and amplifying what you're saying, Aza, maybe it's the cohort looking different in the different ways, or perhaps the same cohort looking different over time. And so I think your great tool kind of allows you to see that as well. And I think that's another thing, not just do the cohorts look different, but do they change in different ways, or they seem to be mostly happening at particular points in time?
So let's look at certain things here, right? So this particular cohort of 9,000 people are people who have a diagnosis but a negative test. These are the people that it's a new definition that we're recommending. That is, they either have a diagnosis or they either have a test or a diagnosis with no negative test on the same time without a positive test. That the complex definition that we're recommending. What I'm bringing up here is hypoxemia. Look at the difference between the proportion of people that have hypoxemia in this group versus that group. That's different, meaningfully different. The respiratory illness, pneumonia, all these things that we know are associated with COVID are meaningfully different in one group compared to the other.
What was 9 again?
The
9 is
9 is the 9 are the people that have COVID diagnosis, but a negative test result within 3 days.
Okay.
So they don't have a positive test result. So the zero positive, 1 negative.
So plus or minus 3 days.
Those are the people you're filtering out, basically.
Correct.
So now you're comparing the people you're keeping, comparing them to the people you're filtering out. So
Yes.
that's your comparison.
And that number 9 is plus or minus 3 days again, or is it just plus 3
Correct.
days?
Everything is plus or minus 3 days in this definition. So what this is telling us is these two groups of people are different.
Well, from a phenotyping perspective, what this tells you is the marker of specificity for C17 is higher in C17 compared to C9, because those are markers of COVID. We think of them as yeah.
Now I'm going to bring another one here. Okay, I mean, it's definitely different. C9 are people that have a COVID diagnosis and a negative test result, no positive. C10 are COVID diagnosis and a positive test, no negative. Okay, so what we are observing already is a difference for many things. What was that, radiology or respiratory pneumonia, maybe? Maybe that's not different. Oh. This is actually the opposite of what we thought it would be. What's Optum DOD?
I just have to say, this is such a cool exercise. This is really, really great to go through.
Yeah, so we have 10 minutes. Now I want to invite a group of people to continue to collaborate on this paper that's going to talk about these insights. And I just wanted to use this. So we need to, I've started an initial draft about this, but need your input, please, and participation to take this to completion as quickly as possible. We're going to talk about what we just discussed. We're going to talk about the various phenotype, what the observations are. We'll put this visual in it. We'll talk about the differences that we found and then come to a conclusion. But I just wanted to pitch that.
But Gowtham, you do need to make it a exercise that can be completed. You need to focus on 3 or 4 cohorts that you're gonna say, based on what we saw in that matrix, on that table, these are the options. One is the 3 plus minus, and then you can think of that may be the most the narrowest approach, and then take Andrew's point and say, no, if a negative result happened in the left side, I'm not gonna think of it as it's totally plausible, and I'm gonna keep it. But I'm gonna drop anything on the right side because I have a problem with those, and that would be your second cohort. And then definitely the first cohort is keeping everybody, because we believe if you have a diagnosis, you have a diagnosis, and that would be your broadest. And then you can make those temporal characterization comparison and start to see your insights. If you have too many cohorts, it's very hard to even understand things. And when we look at this temporal, you're going to look at markers of COVID, but you're going to look at markers of what Anna brought. The assumption here is that you have that people, because these people are doing an elective procedure, and the diagnosis there is to justify the test, which will come later with a negative result. So you should look at things that are not related to COVID, like elective procedure, and see if truly more prevalent in those negative people versus the other cohort.
Yeah, and as you're winnowing these down, Gowtham, I'd like to run these through Evaluator just to see what we have. So when you get down to, I don't know, top 6 or something like that.
Yeah, absolutely. So I'm intending to do an exercise of whittling this 22 to at least 10 or less before end of day today. I don't know if it's possible, but I'm trying to do that exercise, because the intention is those 10 or less cohort definitions will be part of a network study, and that will go to various other data sources. We don't want 20 cohorts to be run on a network study. We want to reduce the number to as less as possible.
Joel's point there, or Joel's saying he wanted to run it through Evaluator, made me wonder, what would you consider as an extremely specific, like 100% specific definition that you might use as like an XPAC? And I'm not thinking about this from a technical perspective of using Evaluator, but what is the one here that we trust completely 100% as correct? Is there one?
Diagnosis and multiple positive tests.
Yeah,
Yes.
or
So
at least one positive
diagnosis
test, right?
and at least one positive test.
And
So
no negative tests.
And no negative tests.
So the group that we are showing right now on the screen.
Okay.
One of the things that
all within 5 days before and after. Okay.
Maybe actually using Evaluator will be very useful to this paper. I'm not sure what you Gowtham thinks of the main messages, but I remember that somebody yesterday, we've been discussing that in different groups. I think yesterday somebody brought up this question, is that for different types of studies, you may need different types of definitions, and sometimes you may tolerate lower sensitivity but higher specificity, and vice versa, right? And sometimes you really want everybody and don't care that much about specificity. So maybe
function, right?
Yeah, so maybe in I don't know how you're thinking about this paper, but one of the versions can be that, okay, here are the challenges that exist in the data, and you cannot approach this phenotype as simply either diagnosis or test. You should be more thoughtful about that, and here are the possible scenarios.
Yep.
Then the next kind of recommendation, conclusion, message, whatever, can be that here are the estimates that we found on the specificity and sensitivity in our data sources. So maybe you should think of what you like when you're investigating and tackling your specific research question. What are you looking for? Are you looking for higher sensitivity or higher specificity? And depending on that, you may want to use one of the definitions that we provide you out of those, like 9 or 10 or whatever we put in the paper. You know what I mean?
Yeah, I see what you're saying. I think that there has to be, based on the study, like you said, we may need different sensitivity specificity trade-offs, and saying upfront that this one may lead to be more specific and this might be more sensitive is a good idea, I think.
So that's what we have currently in the vaccine safety group. Like this phenotype is to feed for those two activities. And maybe to Erica's paper, she just want to characterize the ASIs in COVID population. Maybe she should go with the more sensitive because she doesn't care. There's no, but for the estimation studies that Martin and the group are leading, like me, the noise is important because they're thinking about effectiveness, or the work you and George did, Anna. Like in that case, maybe you want to lean towards a more specific definition. I mean, I'm not a big fan of I'm a big fan of one definition, but maybe.
For the process of winnowing down from some initial number to a number that's closer to of interest, it would be really useful to develop something. I'm not sure if it's a Tisney plot, probably is something similar, where you have essentially a distance metric, some normalized distance metric in n-dimensional space, where you got a threshold for like what's of interest, and you say here's how similar and different these things are in some way that kind of summarizes across all of that. It's all the information is there. Having to scan it visually is a useful, wonderful thing. But it affords the opportunity to do something based on those quantities that kind of summarizes all of that in a succinct way. It can help you say these are really very, very different, and these are not, and some quantitative assessment of that. So I just want to note that. I think that's a really cool opportunity that this approach presents.
Right now we have two-dimensional space. We don't have n-dimensional yet.
Well, but there's tons of metrics. I think Andrew's point's spot on. We can be doing cohort similarity by just treating the covariate space as a vector, and then you can just quantify cosine similarity across the cohorts. It's a more objective way to do it than just eyeballing things. I was assuming, Gowtham, like when you showed the first thing, like you have some cohorts that are like explicitly identical. Like you've got one where you like require the zero test, but then I gave you the logic where you don't require the zero test. And those two cohorts are identical. There's clearly no reason to need to run those because we can actually logically prove that they're identical.
C16 and C17 are identical.
But when we talk about subtleties of like, is this a little difference or a lot? I agree with Andrew's thinking there. I think, having a quantitative approach would be a really nice way. And I think more broadly, being able to compare cohorts on some sort of objective cohort similarity scale would be a really nice methodologic innovation.
I got a question, I guess, on the approaches that evaluator might take versus Aphrodite, and one, maybe you could kind of chime in. One of the things I've only kind of used the latter, so maybe they wind up kind of boiling down to the same approach. So one of the things that was useful in that kind of anchor and learn process was having that kind of reinterpretation in the loop, so you could see what kind of what features were boiling out with each learning cycle. And is that something that the evaluator allows you to do? Because you always have to be cautious around how much inference you're making with some of the features that show up, but it can be useful to see if there's some possible inference there in terms of what you might want to include in a rule-based definition later.
Yeah. To see what the best predictors are, and then be able to add that later. Yeah.
So those are the cohorts that are opposite of each other that you're showing on the screen, Gowtham?
Yeah, right, that's right. This is the C9 and C10, the C9 being the one that has a diagnosis and a negative test result, no positive, while the C10 is the positive diagnosis and a positive test result.
So they have a lot of measurements that are higher in C10.
Yeah, and that, correct. And that's probably an indicator of like pulse ox.
So oxygen, interesting.
Respiratory rate.
And C10 was the negative, right?
The C10 is the positive. COVID diagnosis.
Yeah.
And
yeah, so this is what I say, like, yeah, it's possible that you have negative, like to Andrew's point, but there is evidence here that those things are related to COVID that are like, this is suggestive that C10 has a higher specificity.
Right.
But
Andrew's point was this is plus or minus 3. Andrew's point was just taking out the -3. we still don't know. You know, the vast majority of these people could be all in the, you know, after the diagnosis.
Correct. I mean, the numbers, though, the numbers in the matrix showing you that it's a combination of both, but the people on the right side were higher, like they were higher on the list. So yes, yeah, you're right.
Yeah, that's right. This is.
Yeah.
25% cough in the one group, 10% in the other. Okay, so next steps for me, the action item is to whittle down the number of cohorts that have been presented to a handful, less than 10 for sure, maybe as low as 6 or 5, and finalize a study package that will be on a Odyssey Studies GitHub page. I have one right now, but I'm going to whittle down the definitions. I'll make that announcement on Sunday evening or Monday morning, and the certain data partners have volunteered to run it. So we're looking forward to collaborate on that and get that executed, and we'll bring those results into one application. So that's one task. The second task is to clearly tell the story. Like we discussed several narratives here. So I'm going to go back, try to capture those narratives as bullet point, just like we did last time, and then try to push this manuscript further on that. So those are the two things that I can think of right now.
Can I clarify from the group for the task of coming up with a list of whatever 5 so number of cohorts? Jamie's point about that most specific to what we believe is true. I know Joel would lead that for if he evaluated, but for this exercise, do we want to think of cohorts that are like more specific than the one that is just like a positive test? Should we check the ones that are very, very specific, or like
essentially
well, to Evan's point, you can add in more other predictors. You could add in symptoms, or you know, you can add in respirator or pulse ox, low pulse ox or something.
Correct, but my question is, Jenna, for this exercise, we're trying to improve the specificity, the specificity, but do we want to improve it? Do we want to explore cohorts that are like very restrictive? But
one question would be: are you, is the distribution we're targeting? It's not just, I guess the concern I'll state up front, if we try to get more and more positive tests or more markers of healthcare activity, you're probably going to start to find more and more people that have been hospitalized. So if you're actually trying to get just somebody that has an outpatient diagnosis of COVID, which the vast majority of them are and remain, then then I think the one that you want is the one that's best tuned to that, which might just be, day 0 diagnosis, day +1 positive test. You know what I mean?
Right.
Right. If we get too specific,
it becomes a different. So go ahead.
Essentially, it's like people that have had a more severe course.
It becomes closer to this. That doesn't become closer to it. It becomes symptomatic COVID rather than just COVID, right? And so those are just totally different phenotypes, right? That we're talking about. So I think it's so. If you're studying COVID rather than symptomatic COVID, then you don't want to. I guess it seems harder to understand what the value of that extra specific definition gets you with respect to COVID rather than symptomatic.
Yeah, I don't think we should propose any of those. I was just thinking for his access for that paper, would you explore that cohort for any reason? I was generally asking. So when Gowtham think of his 5, where does he start with saying this is the more specific? Is it something more specific than what we have here? Like for fee evaluated, Joel needs a way more specific for his exercise. But I think for Cohort Diagnostic, I think we should limit what Gowtham started as the truth.
This visual will become more compelling if there is a real contrast in the specificity sensitivity between the two cohorts being compared. So we have a diagnosis with a negative test as one cohort, and a diagnosis with multiple positive tests as another cohort, you can expect the scatter to be further compelling.
But we would never propose that cohort to be the one used in studies because it's going to have a horrible sensitivity.
But it'll help us learn what covariates are associated with the most specific cohorts, because then those covariates can then be used for this comparison.
I'm not sure it would, though. I mean, I think if it were really just a more unless there's a different strategy being proposed than the one I understand, I'm not sure it would help you to learn that, because I don't think you're just getting a more specific version of the same cohort. I think you're getting a definition of a different cohort of
You may
patients.
be right. Yeah. You may be right, because it might represent intensity of care, which may be a representation of intensity of disease. Okay, so we are past 2 o'clock. That's the end of the formal part of this group. I'm gonna just stop the recording, and if anybody wants to stay on,